Okay, great. All right, good morning. Thank you very much, Dr. Tran, for the kind introduction. I'm very pleased to have this great opportunity to introduce my mHealth research projects. I would like to start with some background information. Life expectancy and births has increased globally. For example, in China, it has risen from 35 years in 1949 to 78 years in 2021. As more people live longer, the proportion of those with chronic conditions is increasing. For instance, in the United States, 6 in 10 adults are living with at least one chronic condition. Self-management is essential for effectively managing chronic conditions. In this context, leveraging innovative technologies such as mHealth to promote access to quality health care and self-management holds significant importance. mHealth is defined as the use of portable electronic devices with software applications known as apps to provide health services and manage patient information. Here, I'd like to focus on introducing a project that laid the foundation of my mHealth research of leveraging AI in coaching and counseling vulnerable people. This is a 5-year research project funded by the National Institutes of Health of developing an artificial intelligence chatbot aimed at increasing HIV testing in Malaysia. And this project was proposed by collaborating with a professor named Dr. Frederick Otis from Yale University School of Medicine. And here I will focus on the study design rather than the study results. In the literature, there are 2 levels of mHealth interventions. To bring population-level effects, the next generation of mHealth intervention needs to be automated for use in real clinical settings. Artificial intelligence using machine learning can potentially achieve this goal. Artificial intelligence is defined as the simulation of human intelligence processes by computer systems using machine learning. And machine learning is a method of data analysis that can automate analytical model building to learn from data inputs, identify patterns, and make decisions without human intervention. I believe that the next generation of mHealth interventions needs to be automating personalized messages, modifying them based on responses, and providing new outputs in real time. Therefore, after conducting several mHealth research projects in China, I proposed to the National Institutes of Health an mHealth project of developing an artificial intelligence chatbot to increase HIV testing in Malaysia. This project was funded by NIH. There are 2 phases in this project. In the R21 phase, I will develop and pilot test the AI chatbot. And in the R33 phase, I will evaluate the efficacy and implementation outcomes of the AI chatbot for HIV testing. We focus on HIV testing because HIV testing is the entry point for both effective HIV prevention and treatment. Yet access to HIV testing is challenging for key populations, including men who have sex with men in Malaysia. Malaysia, a middle-income country with 32 million people, has an HIV epidemic that has transitioned from people who inject drugs to sexual transmission, mostly among MSM. Vote testing is associated with high levels of stigma and discrimination towards MSM, which is heightened in Malaysia, where same-sex behaviors are criminalized. For example, police raids of venues where MSM frequent, such as bars, saunas, and massage parlors, also publicly humiliating them by parading them in front of television cameras. Studies have documented that societal discrimination toward MSM extends to clinical care settings among medical students and physicians. Consequently, MSM must navigate individual, clinical, and policy barriers that perpetuate stigma and discrimination to minimally access HIV testing. mHealth strategies can potentially overcome such barriers if they use theory-guided behavioral change interventions to overcome multi-level barriers to HIV testing. Smartphones and apps are ubiquitous in Malaysia. Studies in the US China, South Africa, and Peru find mHealth interventions as acceptable and significantly increase HIV testing by helping MSM overcome barriers by providing real-time information, motivation, and behavioral skills. Despite the benefits from these early mHealth strategies, they have not yet been scaled up because their design requires high intensity and sustained human inputs. For example, they often require researchers to regularly and manually send personalized reminders, provide real-time guidance, and initiate referrals. I proposed using an AI chatbot to overcome this limitation. An AI chatbot is a computer program with machine learning algorithms to simulate conversation with human users through mobile apps. The AI chatbot that we proposed is different from a prescripted chatbot. A prescripted chatbot can only give predetermined answers. It cannot learn from data and therefore cannot update itself. Here is an example of a prescripted chatbot. On the right side of the slide, you can see the chatbot. On the left side, it's the algorithm of the chatbot. The chatbot interacts with participants by following the algorithm. However, in real clinical settings, healthcare clients, they do not follow the chatbot algorithm. For example, the chatbot asked the participants, testing every 6 months is recommended behavior by WHO to prevent HIV/AIDS. Do you want to learn more about HIV testing? Instead of responding yes or no, the participants asked a question. Do I need to visit a local clinic for HIV testing? Because this question is not embedded into the algorithm of the AI chatbot, of the prescripted chatbot. Therefore, the chatbot does not know how to respond to this question. We will develop an AI chatbot in 3 steps. First, we will identify our social networking app for embedding the chatbot, because different populations interact with social media differently. We need to identify apps most commonly used by MSM in Kuala Lumpur to improve generalizability. Next, I will develop and pilot test the AI chatbot with assistance from an AI engineer. Later, the findings from the first 2 steps will inform our type 1 hybrid implementation science trial to evaluate the efficacy and implementation outcomes of the AI chatbot for HIV testing relative to treatment as usual. We have created the algorithm of the AI chatbot using decision tree model. Specifically, we first created our baseline script using the decision tree model. In the model, each root node represents a question initiated by the AI chatbot, and each decision node represents an answer provided by participants. The leaf nodes are action plans suggested by the AI chatbot. Those questions and action plans are targeted, tailored, and personalized specifically for MSM along the HIV care continuum and based on information, motivation, and behavioral model of HIV prevention. The script has been reviewed and modified by our community advisory board, including MSM representatives. Based on the algorithm, we created the prototype of the AI chatbot, and we conduct alpha testing within our internal team members. The AI chatbot is able to provide information relevant to HIV testing, PrEP, and mental health. Participants can order free HIV self-testing kit through this chatbot. And also, we embedded 220 MSM-friendly clinics into this AI chatbot. After the alpha testing, we conducted beta testing among 14 participants. In each beta test, we will conduct 3 steps. The first step is a 45-minute human chatbot interaction. We provide this chatbot to participants to interact with. And after the interaction, we conduct a semi-structured interview to ask for feedback. And after the interview, we conduct an online survey to collect further feedback. After the beta testing, we conducted a national observational study in Kuala Lumpur, Malaysia, and we recruited 334 participants and documented 393 human chatbot interactions. And currently, our team is analyzing the data. And based on the data and the feedback, our AI engineer will incorporate the feedback into the algorithm of the chatbot using Python and Prolog programming languages and incorporating machine learning into the algorithm to generate automated messages. Our next step will be conduct a randomized control trial to recruit 2 groups of participants. And we plan to recruit 296 participants, and the study will last 180 days for each participant. In addition to this mHealth project in Malaysia, I also initiated mHealth research projects in Cameroon, US, and Indonesia. Here, I want to briefly introduce some of them. In Cameroon, adolescent girls and young women are the most vulnerable population for HIV/AIDS. Therefore, we are leveraging augmented reality, AR, to improve their medication adherence and promote their awareness of PrEP. And AR is a technology that can superimpose computer-generated information onto real-world environment. And specifically, we're going to create an app. In the app, there will be an avatar, which is embedded with the AI algorithm that can interact with participants. And in the US, Black MSM are the most vulnerable population for HIV/AIDS. Therefore, by collaborating with Dr. Laurent Nelson from Yale University School of Nursing, we are collaborating with 4 clinical sites located in 3 states of the US, Florida, Georgia, and North Carolina, to develop an AI chatbot to promote PrEP awareness and uptake. In Indonesia, cardiovascular disease is a public health concern among people residing in rural regions, particularly among those living with HIV. By collaborating with Airlangga University, located in Surabaya, Indonesia, we are initiating a project of leveraging virtual reality to increase people's awareness of the importance of taking antihypertensive medications. Well, thank you for your attention. I look forward to your questions. Thank you.